It's time to get the story behind the story. Interviews with newsmakers, news breakers, and Vermonters making a difference. WCAX presents 802 News with Mark Johnson. Here's Mark.
There are 85 rank-and-file members of the Burlington Fire Department. They work 48-hour shifts followed by 4 days off. On average, they work a 56-hour work week. Overtime after 40? That doesn't apply in this line of work. Every BFD member is trained to put out fires and respond to medical emergencies. They are committed and dedicated. For many, it's more of a calling than a job. But their role on the front lines of the opioid crisis is taking its toll. Call it compassion fatigue. Here's why. In 2018, paramedics and EMTs responded to 179 overdoses. This year, it's almost 400, with 3 months still to go. On one recent 48-hour shift, BFD responded to 56 overdose calls. Rescue workers say it's not uncommon to administer Narcan to the same person more than once during the same shift. For some newer drugs, Narcan doesn't even work. In this edition of 802 News, sponsored in part by Red Hen Cafe and Bakery, we hear their concerns. Here with 3 members of the Burlington Fire Department. Kyle Blake is a lieutenant. Jeremy Raymond is a lieutenant. John Husbands is a firefighter. All 3 of them are members of the Burlington Firefighters Association, and that is the capacity in which they are chatting with us here today on 802 News. And the reason that I asked the 3 of you to join me today is I know that the opioid crisis has had an impact on the work that you do. Kyle, why don't we start with you here and give us some sense of, how has the opioid crisis affected particularly the second part of your job, which is not just to put out fires, but to also rescue people that are in medical distress?
Absolutely, Mark. Just real quick, the first little disclaimer, right? Our opinions, our views that we're sharing today don't necessarily reflect the city of Burlington or the fire department, right? Like that people put on their Twitter accounts. These are our views. So we just need to make that clear. We're speaking in the capacity of the union right now. To answer your question, it's been challenging. The call volume, the last projections we were looking to hit over 11,000 calls for service in the year, which would be about over 1,000 more than the year before, which was 2,000 more than the year before that. So the trajectory is of a rocket ship headed to the moon, in our opinion. The types of calls that we're seeing as well as a result of this epidemic are challenging to handle for the fire department or our members, because they're new and it's a complex type of call. It's no longer the cardiac arrest. We have a protocol for that, a very clear algorithm that we go through. We know how to handle them. You break your arm, we can splint it. You cut yourself, we can bandage it. You get stung by a bee, you're allergic, we'll give you epinephrine, we'll take care of that. When we have individuals that are overdosing on polypharma substances where it's no longer just an opiate anymore, we don't really have the tools appropriate to handle those. We're doing our best. Back when fentanyl first started to come into the community, Narcan was the golden bullet. You could give Narcan. We would always try to titrate to effect, so that way we're not abruptly ending or snapping that person out of an overdose, which can also cause problems. But we're making sure that they bring back their respiratory drive, that they're safe, and then we would transport them up to the hospital so they could get to definitive care, make sure that they're stable, make sure that when the Narcan wore off, they didn't go back into an overdose capacity. What we're seeing now with these polypharma substance compounds that people are taking, Narcan won't work. Narcan will address the opioid problem that they're experiencing, but with xylazine, it will not do that. I think it's also called Tranq, but that's being mixed in. So we're now having to provide more respiratory support with our bag valve masks, supplemental oxygen, those types of things. Additionally, the patient demeanor, we've also seen a significant change in that. When I first came in 9 years ago and we were running overdoses, we would give someone Narcan. They would be stunned that they had overdosed. They would be, when we would say, they'd be like, "Why are you here? You almost died. Like, you were blue, you weren't breathing, your friends were panicking. We gave you this thing called Narcan. You're now breathing again. We need to get you up to the hospital." "Yeah, let's go." John can speak more about this because he's on A1 right now, our busiest ambulance 1 out of the downtown firehouse. You give someone a little Narcan and they come to, they're mad. They're mad that you took away that high, or they might be at the point where they're chemically dependent on that, and now you've potentially pushed them into a withdrawal state, which can be very unpleasant for them. So they're mad about that, and they're swearing at us, threatening us, refusing to go to the hospital, and it's difficult. It's a whole new world that we're living in now. I mean, we'll have people after we give them Narcan, pop up and say, "This is the second time today someone's given me Narcan, like, just leave me alone." But the only reason we're there is because someone in the community saw someone laying on the sidewalk, unresponsive, was concerned for them, so they called 911. We show up, we see the same thing, we're concerned for them, we try to help them, and they're mad about it. And we don't hold it against that patient. Like, we haven't lived their experience, we haven't walked in their shoes, we don't know that. So we try to be compassionate, we try to support them to the best of our capabilities, but that support is starting to seem like it needs to come from somewhere else than the fire department's emergency response vehicles and our membership.
Tell me about the difference. You said you've been doing this 9 years. So how many calls would you get in a typical year, say 5 years ago, compared to today? OD calls.
Overdose calls. I don't have numbers, and I don't want to make a number up and then someone goes and finds out that I was off by 10 or 100. So I will give you this. I will say, back when I first started, I could probably remember each and every overdose call I went on for that year because there were so few of them, at least that I personally responded to. Now, just the other day, John's shift went to 56 calls in a 48-hour period that were just unresponsive, potentially overdosed patients. That's what we were dispatched to. 56 in a 48-hour period. For the total shift, they ran 123 calls for service. That's unreasonable, I think, realistically, for what we're staffed with, our capabilities. But 56 of those, drilling into it, were for potential overdoses, essentially. An unresponsive patient, possibly overdosed, maybe Narcan's been delivered. So going from, I could probably remember each and every one of them, count them on my hand, easily be able to look them up, to, in one 48-hour shift just a couple weeks ago, they did 56 potential overdoses.
John Husbands, tell me your thoughts on what Kyle just said.
I echo his same sentiment, kind of the general feeling of feeling overwhelmed and helpless, kind of in that sense. More of the, not just in a pure workload, work capacity sense, but I feel like, at least for myself personally, my wife and I picked up and moved across country to come to Burlington for this job and to live here. And I'm very, very passionate about what I do. Along with these other two gentlemen with me, I feel like we are known in our community for being passionate about, especially, Jeremy and I, medicine. I love what I do. And, I didn't start this at a young age. I've had many jobs. I was in the military. And this is the calling that I found that speaks to me as a person, as a soul, able to do what I can to help other people. And I'm very passionate about it, and it's very fulfilling to me. At this point, it is very difficult to maintain that level of passion and empathy and intimacy with the care that I provide, because of the volume, and not just the high volume. It's not just being busy. It's what we're required to do and the feedback we receive. It's extremely challenging. And to know that you're going to go on possibly at least one overdose an hour every single hour that you work without sleeping for 48 hours can be difficult. And not only that, then going to the scene, giving advanced level care to people that are literally dying, and then having them come back with, aggression or violence or anger or the cyclical, constant same thing from the same person and multiple times. It's defeating, I think is the best word for it. Where I initially, and I've only been here for 2 years. I worked in the emergency medical system in San Francisco for 5 years, so I have experience with it and same things on a much larger scale in that city. But I don't have that outlet of passion as much as I had 2 years ago, because I don't feel like I'm doing anything.
Jeremy, can you talk to that same issue?
Sure, Mark. Yeah, just for me on a personal level, being from Burlington, I kind of take it just a little personal, seeing how difficult some people are really struggling with this epidemic, and what our guys are trying to do for them, and just in a roundabout way, we're trying to solve the problem, and we're seeing it every day. And as these guys have mentioned, we're seeing some patients 2 times a day, 3 times a day that have already been Narcaned, and the situation just isn't getting better. And it's not getting better for them, and it's not getting better for us. And I think it's coming to a point where something really needs to happen. You asked that question and talked to Kyle about how many people have you Narcaned when you first started. And what I thought about was, when I first started, we used to have to call in to med control to administer Narcan. And there were 3 things we needed. We needed unresponsiveness, pinpoint pupils, and shallow respirations. And now Narcan is so readily available to get and to use that, that just kind of speaks to how rare it was to give Narcan, that we actually had to call a doctor when we got on scene to see the patient having these symptoms. So I think that really just triggers in my mind just how much things have changed over time.
They're talking about giving it out so that it's available over the counter.
Yeah.
They almost already do. Down at the needle exchanges, patients can receive Narcan. They hand them out. We carry what are called leave-behind kits on our trucks that have information about substance use disorder counseling. They have Narcan in them. I believe the new kits now additionally have fentanyl test strips in them, and they're talking about trying to add xylazine test strips into those kits as well. So Narcan is out there. It's good it's out there. It's probably saved a lot of lives. I can't tell you how many times we've shown up to a call and Narcan's already been delivered by a passerby, the person's friend, the police officer who got on scene before us. So Narcan works when it's purely opiate-based, and Narcan does great things. It saved countless lives within this community. So I think it's good that it's there. The one concern that I think we see is that, and we're not psychologists, we haven't dove deep into this world. We're just going off of what we see. But the question that, we sort of throw around is, because Narcan is so available, does it allow someone to push further, to take a bigger dose potentially, because they know they have that parachute readily available? And then if it has xylazine in it, the Narcan doesn't work. Xylazine is a new animal that is wreaking havoc, I think, on the Burlington community, especially those that are experiencing, substance use issues, that they become dependent on it, and now, for whatever reason, somebody somewhere decided to put xylazine in it, and it's horrible.
Educate me. What is that?
Xylazine, I believe, it's originally a tranquilizer, sedative.
Horse tranquilizer.
I recently attended on behalf of the department, but it's open to the public, ComStat. It's a meeting put together by the city. It brings together a bunch of people involved in the opioid crisis in different avenues. There's the private sector, the nonprofit sector, law enforcement, healthcare providers, addiction counselors, the mayor's office. They all are coming together to talk about the opioid crisis. And the one I attended had a doctor from UVM that was talking about xylazine and how it acts on the body. And some of the counselors that were there were sharing, their clients' experience, where they were saying the xylazine the person goes from I'm here, I'm present, to they're out and they don't remember it. But like with any substance, they slowly build a dependency on it, and then they need that in order not to go through withdrawals. So it's scary. I can't imagine what they're going through. Additionally, xylazine, and the doctor said they're still trying to figure this out, will cause necrosis of the skin, not even at the site of injection. So basically tissue death. We're seeing these patients have open sores. They get a wound, it doesn't heal the same way, but it's not like with the opioid crisis, where usually that necrosis, death of the tissue, was at the site of the injection. They could have it just randomly pop up on their back, an open sore, and they're not sure why this is happening.
All right, let me ask you this. We're talking with Kyle Blake, Jeremy Raymond, and John Husbands, all members of the Burlington Firefighters Association. They are not only firefighters, but EMTs. They're the people that come and rescue us if we are in medical distress. On these opioid calls, John, is there a threat to your personal safety? And if so, what is it?
I would say absolutely. I mean, as a baseline, just for the nature of our jobs and our careers, there's always a heightened level of danger when you're responding emergently to any sort of situation, whether it be a fire or a cardiac arrest or an overdose. But what we're seeing now in the locations, situations, and with our staffing, not that we are understaffed, but just with the high volume that we're seeing, there's a higher level of danger because of the unpredictability. And I think danger comes from any situation that's unpredictable. If it's predictable, then you can deal with it in a safe manner. But when we're responding to overcrowded areas in the middle of the night for people that are polysubstance drug users, and we don't know them, we don't know the situation, we have to assume a lot of things going into that in order to treat them emergently. And saying we do that all effectively, then there's also on the back end what we discussed earlier, that in order sometimes for the heavy doses of polypharm involvement in some of these people, bringing them out of that can be almost as lethal as having them overdose. So you have to be very careful with how much Narcan you give someone, because not only do you have to fear for your safety, but it can be very dangerous to bring someone out of an overdose and throw them into immediate withdrawal.
Tell me more about that. Why is that?
People that live with, especially opioid drug use dependency, their body has become accustomed to it, and their opiate receptors have developed kind of a relationship with a level of narcotic in their body at one time. And so
resistance.
And kind of a relationship. So the reason that opiates are dangerous and kill people is not just because it's a scary drug, it's because it depresses your central nervous system, which controls your breathing. And so the breathing issue is the main thing that heroin users, fentanyl users, now xylazine, even though it's an opiate, it similarly is characteristic, where as a sedative, it depresses that central nervous system. And the problem that we're seeing is we can no longer have the golden ticket to bring that back. That increased level of danger for the patient inherently in our relationship with them on that scene increases our level of danger, because it's more chaotic and it requires more manpower. And you saw the other day on that shot on the news I'm in that shot of us carrying that person out of the bathroom that was overdosing. It takes 7 of us just to deal with this one person, let alone multiple people, let alone scene danger or in the middle of the night and all the needles that are on the ground, and you don't know if this person has anything in their pockets. And there's always a level of danger when you go to these calls, especially with high frequency. And if there is a minute amount of danger in anything, if you increase the frequency, it just goes up from there.
What's that? How is that impacting your ability to respond to the heart attack, for example? Kyle, you want to?
To piggyback off of what John was just talking about how many resources we need just to handle that one overdose. Anytime the frequency goes up, it's a bigger draw on the system. It depletes our resources. If we have 3 patients in City Hall Park suspected of overdosing, which isn't necessarily that uncommon now, that's 3 ambulances potentially that are all going to City Hall Park. That's ambulance 1, ambulance 2, and ambulance 4. We no longer have any ambulances in the city at that point. We're relying on mutual aid. We're relying on South Burlington maybe have an ambulance free that could come in, UVM Rescue to send an ambulance. So it would have a potential to delay care to be able to be provided for that person having a heart attack. To be very clear, though, an overdose to the point where the person's respiratory drive is at the level where it can no longer support them is just as lethal as a heart attack. And so it needs to be treated like a true medical emergency. The frustration that maybe you're hearing from us or seeing with some of the stories out there is that we are not going to true lethal overdoses, thankfully, that much. We're going to these lower level, unresponsive. They took the drug that they chose to take. They're experiencing how it's altering them. And then they happen to be in a public area where people see them, are concerned, and call. And then we show up and honestly, at times, complicate the issue for that individual. And we have protocols we follow as state licensed EMTs, advanced even EMTs, and for Jeremy being a medic and John soon to be a medic, we have to follow state protocols. And so when we show up to someone who's altered, which you would be under a substance like that, and we define altered as like mentally altered, they're not able to answer questions about who they are, where they are, what's going on, maybe slurred speech, they're stumbling. We have concerns that if left by themselves, they might not be okay. We are supposed to, per protocol, transport them because we cannot be confident that they're making an informed decision about their own health. But then you have the individual that we either got Narcan before we got there or we gave them Narcan and they come to, they're still altered, but they're yelling at us, they're aggressive. And it's this fine line of how much do you push to try to medically make that individual safe, ensure that they're not going to go into another overdose again as soon as we leave, ensure that they don't stumble out into the street and get hit by a car, versus are we doing more damage by arguing with them and trying to convince, elevating their attitude, spiking their heart rate, making them become aggressive and hostile and storm off from us. So that's something we always struggle with now on these calls is, are we doing, and it's a question I ask myself, I won't speak for these two guys, but I'd be shocked if they're not asking the same question. Are we doing potentially at times more harm for this potential patient than good by interacting with them in this way?
What do you mean by that?
Showing up with a fire truck, an ambulance, 5 firefighters, lights, sirens, police response. I wouldn't be happy if I was sleeping on the sidewalk and that showed up and guys are trying to tell me I need to go to the hospital. No, thank you. And in fact, now I potentially have the concern that I'm going to start going into withdrawals because I was given Narcan. It complicates things so much, and we will always respond as if that's our protocol. The call comes in, we get on the trucks, the wheels start spinning, we're going. And if it is a potentially lethal overdose, we are doing everything in our power to correct it and provide appropriate treatments. A term that has been floating around a lot lately, and one you might have heard, but it's something that's become ever more prevalent within the fire service, the EMS world, is that of compassion fatigue. And I think when John was talking earlier about what he's experiencing right now, that is compassion fatigue. That is, we all get into this job because we want to help people. We have compassion for somebody who is going through a difficult time, experiencing potentially the worst day of their life, regardless of what that is. One of the big things that we try to focus on is just because it doesn't seem like a problem for you with your lens that you view life, doesn't mean it's not the worst day of that person's entire life. But it becomes hard to continue to offer that level of compassion when it always seems like you're just met with staunch resistance over and over again anytime you're trying to help. So I think if I could get something out there, if people are listening, that is what a lot of not just us, any first responder in your community, wherever it is, compassion, fatigue, potentially the sense of being defeated over and over again. We're human too. We have emotions. A lot of us like to pretend that we can see the worst of the world and carry on like it doesn't affect us. That's just not true. And seeing people who are suffering and you want to help them and just being turned away time and time again, and so often that you become numb to it, is not healthy for anyone. And so we want this to get better. We don't want to see these people out there. We want them to be getting services that mean that we're not showing up with an ambulance, a fire truck, and 5 firefighters trying to do whatever we can in our power to help them, because we get that that's not the answer all the time. And we're dealing with potentially an antiquated response system that, because it's a medical call, the ambulance and the fire truck are going.
We're talking with Kyle Blake, Jeremy Raymond, and John Husbands. They're all members of the Burlington Fire Department and also here in their capacity as members of the Burlington Firefighters Association. I want to make here at this point in our discussion one thing perfectly clear too, and maybe Kyle, you could address this. I contacted you guys. You have not contacted me about this.
Correct. Yeah. No, you did reach out, Mark, and we were actually having a conversation on our walk over here about, there was some hesitation on our part to do this interview because we don't want the community to feel like this is us complaining, or we don't want them to feel like we don't like our job, that we are sick and tired of it. That is absolutely not the case. And as we were walking over here, we were talking about that a little bit. It's like this is not a Burlington Firefighters Association media event press release where we're trying to, stir the pot or
get more money
or anything like that. You reached out to us as a resident of Burlington of what you're experiencing yourself, what you're seeing, and asked the question. And I think, we view this as a great opportunity to have a kind of organic discussion about what we see, what we're experiencing, and even more so, how it's affecting us.
Do you think people in Burlington have any idea what you're going through?
I think they're starting to more. I think we are so fortunate as members of, the Burlington Firefighters Association, working for the Burlington Fire Department. The level of community support that department and our members receive is wonderful. Like, the community, I can't tell you how many times we'll get thank yous, keep doing a good job, can't believe what you guys have to deal with, thank you for your service, all of that stuff. So the community truly supports us. To your specific question of they truly know what we're seeing, I don't think so. I don't, numbers are one thing. Yeah, it's shocking when we say we responded to potentially 56 potential overdoses
in one
48-hour shift. Yeah. That's a what like that's, and we have to clarify, right? It's not overdoses to the point we're transporting them to the hospital, but this is a strain on our operational capacity and a strain on, the employee. But those are just numbers, right? But then when you start having the discussion with them and you start talking about the interactions we're having with patients, the potentially hostile environments that we're going into. You asked about our safety earlier. Because our call volume is going up, the police call volume's going up, and they also have fewer patrol officers on the road at times. We are now entering into environments that we typically would have never gone before without having a law enforcement officer with us. And that law enforcement officer, very rarely, I can count on just one hand in my 9 years that officer, that the police officer actually had to interject to provide scene safety or protect our members. But it was more of that just insurance policy that if this patient that was on some sort of substance got violent, pulled out a weapon, anything like that, we had that backup. We had an individual that was trained to deal specifically with those types of threats. But amphetamines are on the rise in the community as well, which have a much different human expression, I guess you would say. Fumbling for a word there, but basically higher level of aggression.
How people react.
Yeah. So oftentimes too, the community members, or the unhoused individuals, the people that lack shelter, often they're carrying knives, they're carrying weapons because they want to protect themselves. Now you mix that with being under the influence of an amphetamine, where your aggression goes through the roof. It's a very dangerous situation. So it's more those types of situations. We would never knowingly go into a drug house, a drug den, whatever you want to call it, where we know there's a ton of weapons and hostility. We'd always stage for PD, and PD would be there. It's those 2 a.m. in the morning, we get called to City Hall Park. The 5 officers who happen to be on in the city are down in the South End dealing with another issue. We got to deal with the patient. What are we going to do? And we've been extremely lucky for the most part, but we're worried that our luck is going to run out a little bit.
Jeremy, can you talk? You've been doing this 14 years. You're actually the most senior of the group. Talk to me about this issue of compassion fatigue. How are you feeling on that?
It's tough. I got into this job to be a problem solver, to help the community. One thing I think about too is the junior people that are coming into the department. We're starting to be a younger department, and we're attracting a lot of great candidates, a lot of people from different backgrounds. Like we have John from California. Kyle, where were you from?
Well, I was from Essex.
Kyle was from Essex, so Kyle's a rarity. But we are attracting a lot of people from a lot of different backgrounds. And as a lieutenant, I find it really challenging to have these junior members coming up with this opiate crisis, just to motivate them, to get them over this essentially hump, and hopefully we can get to the light where things get better. And a lot of my friends ask me, is just like, what's it like being a firefighter? Like, what do you do? It's most of the people think, we're putting out fires all the time. We're rescuing cats out of a tree. We're doing like what people think we're doing as firefighters. But really, as we're talking about this whole subject, it's the opiate crisis. So the hardest thing is really just, educating like we're doing right now, is just, putting a voice out there and letting know people how we're feeling. And, again, just a lot of junior people in the department, and just making sure they're well trained, not going into dangerous situations like we talked about. We're training on that constantly. And it's really just keeping each other in check and just looking out for each other, and essentially putting our safety first, and then being problem solvers like we want to be.
When did this really amp up?
It's hard to say. COVID really threw a wrench in the mix. So, that was like 3 years. And, honestly, for me, it's hard when we were going through that as a department with so many protocol changes and a different type of safety. But, it's really hard to put an exact date on that. But it's all, everyone has a different opinion on, what's good, what's bad, what's in the middle. So it really is person dependent. And, John's on the ambulance, and he sees it a lot more acuity of what goes on, especially in the district that he serves. And I can let John speak to that.
Yeah, just to your previous point about kind of a date and time, I think there was a simultaneous ramping that piggybacked in to our lives on the back of COVID. That was mental health, which kind of facilitates and goes hand in hand with illicit drug use and abuse, and lack of resources combined with COVID, which cut a lot of people off from their support resources. So I think it was one of those perfect storm things where the hum of where everyone noticed it was kind of at right before and in the beginning of COVID was where this ramp up into our most recent opioid epidemic kind of sparked.
I mean, you mentioned sort of that there were mental health issues that came out as a result of COVID. I think most people would acknowledge that. Is that where you kind of see that this is why this is happening?
I think you would be very hard to find someone that is an opioid drug user consistently that doesn't have mental health issues as well. I think it is a tool, an addiction, and an escape all wrapped up into one that allow people, unfortunately, that are in very desperate times and very difficult situations to remove themselves from that.
That was just John Husbands, a firefighter. Jeremy Raymond is a lieutenant, and Kyle Blake is a lieutenant. All members of the Burlington Fire Department here in their capacity as members of the Burlington Firefighters Association. We'll continue our discussion in just a moment. At Red Hen Baking Company, they believe pure, uncomplicated ingredients in the hands of skilled artisans are the building blocks for great food. They're dedicated to creating the best food from the best ingredients. You'll find an ever-changing lineup of delicious pastries, sandwiches, and soups at their beautiful cafe off Route 2 in Middlesex, just off I-89. Their breads are also available in many other locations. Led by owners Randy George and Eliza Kane, Red Hen Baking Company has been on the leading edge of the local food movement since 1999. Back to our discussion about the opioid crisis and its effect on some of the members of the Burlington Fire Department. When I hear an overdose an hour, that just sounds like a lot to me.
Yeah, that's an eye-popping number, and to be clear, that was an extreme example. Okay, that was that one shift that was a perfect storm. I think it was very hot. Maybe there was a new, stronger batch of something in the area, or
what's typical?
Ebbs and flows. It's funny, everyone sort of wants to know that, and it's we have shifts. They're rare. They're extremely rare now, but we'll still every once in a while have a shift where you sleep through the night. They're rare, but they do still happen. So to be clear, we are not running nonstop 24/7, 365. We still have the opportunity to train. Typical, I think, just listening to the radio and hearing units go out, maybe 4 or 5 potentially unresponsive people per 24 hours, I think would be a reasonable stab in the dark at that, which is, to be clear, way more than it ever was when I first came in, way more than it ever was when Jeremy came in, and even in John's 2 years with the department and the union now, way more as well. Another compounding factor that I don't think we can deny is the unhoused population, those that lack stable housing. You walk downtown and it's right there in front of you right now. You go to City Hall Park, you walk down College Street, specifically in the downtown area, it's right there. You see it. There are tons of people who, for a plethora of reasons, are unhoused and they don't have stable housing. We see that, we engage with that population because that population is often more exposed to the elements. They're more susceptible to when it's really cold, when it's really hot. They're in aggressive interactions between each other, or they have to deal with cars going by them, whatever it is. But we have definitely seen a call volume increase. Maybe it's linked, but we will have patients who are coming to the station, ringing the doorbell in the middle of the night, saying they want to go to the hospital, that are definitely not under the influence of anything at that time. But it happened to be maybe cold that evening. There was, a little while ago, we had an individual, I think, in one shift was transported five times to the hospital in like a 24-hour period, 48-hour period. The patient would go to the hospital, would leave the hospital, walk back downtown, and then come back to the station, ring the doorbell, and say, I want to go back to the hospital again. We don't have the capacity really to say no. It's very hard under our protocols if someone has a medical complaint or a concern and are requesting to go to the hospital for us to say no. We don't like saying no either, right? This might be not the boy that cries wolf, but yeah, we might have interacted with that individual 30 times that year already, all for absolutely no true medical issue at all. That 31st might be it. And so we always treat it like, you want to go to the hospital, you're telling us it's a problem, we'll go. That is another strain on the system. And that is another driving factor of that compassion fatigue we talked about, those repeat patients who are probably abusing the system. Let's call it what it is. It's abuse of a 911 emergency response EMS system. but we do not lack the tools to address that. I don't think the police department has the tools to address that currently. The emergency department up at the hospital does not possess the appropriate tools to deal with that. So we now have just listed 3 entities, law enforcement, fire EMS, and the emergency department, that are all falling trap to or being taken advantage of by singular individuals. We'll just call 911 and we're taking them into the hospital again. It's a strain on the overall system, and we don't have the tools. The system does not have the tools currently to handle those types of patients.
And I think the worst part about it is that patient isn't getting what they need to get the help. And that really just is a compounding factor to the burden, essentially, that it puts on these resources of the fire department, the hospital, the police department. And it's just a constant struggle, and we are right in the thick of it.
Tell me what you mean by that.
Just for example, if we transport that person 5 times to the hospital and they keep coming back, what's the problem? What are we doing wrong? What is the hospital doing wrong? What can we do to get this person to not call 911? We, like Kyle said, we're always going to answer the call, but we don't want to answer the call for someone that doesn't really need our help, that needs help from some other entity that just seems to not be in the community yet. We're very hopeful. The city, I think, is working hard and definitely is aware of the situation. We're just hoping that resource, whatever it is that they create, will start helping patients, because that will start really helping us. And again, when I say us, the fire department, the ambulance, the police, and the community for that fact.
Yeah. I was going to piggyback on that and say the community as well. My wife is a nurse in the emergency department, and we met in the emergency department. We kind of see the duality, both sides of that circle of care that people get, from picking you up at your house or out on the beach or in the park to definitive care at the hospital.
Wow.
And it's unfortunate that our 3 kind of groups, as Kyle put it forth, are, I don't want to say stuck with a bill, because that sounds like we're not emotionally connected to the situation, but it's a screwdriver for a nail at this point. And there's no other tool that's appropriate or that is funded or that has been come up with, and we already have it, so it's us. And people are stuck in this cycle where they have definitive needs for housing, for mental health support, for proper medication, to wash their clothes, for proper nutrition, that don't have it. And the only avenue is to go to the emergency department, get a sandwich and a warm blanket, and sit there for a while out of the elements until the emergency department, that's totally inappropriate because they're there for medical emergencies. So then they discharge them because you're not having a medical, you do need help, but we don't have the tools here to give it to you. And there's nowhere for them to go. So then they go back to where they were initially, and the cycle repeats itself. And they only slip out of that circuit if they find help, if they move somewhere else and join a different system and just repeat that loop continually, or they pass. Because there is no solution right now. They're shutting down housing. They're going to open a 9-bed mental health ward at UVM, which 9 beds probably my ambulance alone can fill before noon. So there is nothing there. So I feel that everyone wants a solution, and we're all trying to figure out the best way to deal with this problem with the inappropriate tools. And so I think the tool discovery is going to be the biggest thing. Instead of throwing more people and more money and all this stuff at it, we have to figure out what the solution is and develop a solution to fit that problem.
All right. Well, let's see if maybe we can find a little bit of hope here. Any thoughts? And this is not your job to come up with this solution. But if if I handed you the magic wand for 5 minutes here, or if you got the ear of whoever is supposed to be trying to figure this all out, let me have the 3 of you tell me what you would tell those people. And John Husbands, let's start with you. Is there anything out in San Francisco that we could graft?
I mean, I bet you they wish there was, because it's very difficult in San Francisco too. All of the emergency services are overburdened. I can't imagine what it's like now, and I'm sure it's only gotten worse. But when I left, 3 years ago, there were days where we had an 8.5-hour wait in our waiting room at the emergency department. So you show up because you're having a medical emergency, and unless you are literally dying or on the step of it, there's no place for you. So if they can't find an answer with how much funding and people and resources and experience, I feel like this is kind of a newer problem in this city. So we're behind the ball a little bit. We have to play catch up with all the other lessons that everyone else has learned. So if I shoot from the hip, I would say community and organizational support, research and funding to find the appropriate means for serving these people. And whether that is a facility or whether that is a service staffed by licensed people or what that is, there needs to be effort and energy put into developing a system that is not the emergency medical or police or hospital system.
If I had a magic bullet, a magic wand, what I would do with it is I would reduce people's fear of trying something new. Often it feels like the systems of support, programs, policies, they're talked about for so long, and the bureaucracy of pushing the funding mechanism through, the bureaucracy of debating about how to phrase something so that it fits my political agenda or your political agenda, drags and wastes valuable time when we could have boots on the ground and we could just try something. At this point, what if we just run things as pilot programs with the understanding that what we should be doing is saying, what are we looking to achieve? And then we try whatever we can to achieve that goal. Set the goal. If our goal is to reduce ambulance transports due to mental health and or substance use, that's our goal. Now let's try whatever we can to do that. Is that putting more mental health clinicians out in the downtown block to engage with a population to ensure that they're being heard and they're getting the resources they need? Sure. Is it a safe consumption site? Maybe. Is it a needle exchange? I would say no, because I think we have one of those. We need to reduce our fear of trying new things to solve problems that we've never faced before or solved. To John's point, San Francisco has been dealing with this type of behavior, these types of issues, but much longer than us, and they still haven't seemed to come out the other side of it. We need to be aggressive in trying things. Another issue that the community is dealing with is not just the crime associated with the use of those substances, but the distribution of those. Circling all the way back to the safety issue, when I first started, we didn't have bulletproof vests and ballistic helmets on our fire trucks. Couple years go by, we have them. They live in a back compartment underneath a bunch of other firefighter-specific, EMS-specific tools. Now those bulletproof vests and ballistic helmets are riding in the actual compartments with us or right next to our fire gear. We've been to multiple gunshot wounds. One of the most recent gunshot incidences that I responded to was almost the execution style of a young man, or I don't know how old he was, but a gentleman in City Hall Park, almost point blank range, I believe, to his head. And we show up with his brain, out on the concrete, and we provided care. We transported him to the hospital. We did everything we could, but we're wearing bulletproof vests. We're firefighters. We should be wearing gear to prevent us from getting burned. And now we're wearing gear to prevent us from potentially getting shot. So that's another component that's all rolled into this whole mess that I think is important to discuss as well, because there's the medical issue, there's the public health issue of substance use, there's also the public safety issue of the crime that can be directly connected to that substance use, whether it's the crime related to having to purchase those substances, fund your ability to purchase those substances, the crime associated with being under the influence and being aggressive or not really in control of your own body, and then additionally the crime of distributing the product and trying to make money off of a vulnerable population. Like, that's the perfect storm. And Burlington seems to be in the eye of the hurricane, except that's not an appropriate analogy because the eye of the hurricane is the calm. And we're not at the calm. We're at the gale force winds, I would say.
How close is your system? How close are you as individuals to, a system failure, breaking point, however you want to describe it? And we'll start with you, Jeremy.
Over the 14 years of my career, there's been ups and downs. I'd be lying to you if I, to tell you that I thought about doing another job. There's a lot of opportunities out there. The world's a big place, but I am built to do this job. I didn't pick this job. This job chose me. Being from Burlington is just another level. Even if the system breaks and crumbles and whatnot, I'm always going to be here. This is not what I signed up for, but I have so much passion, just as John has been echoing over here too, is not only for the job, but just for the city. And I just don't want to let him down. So as tough as it gets, we have a great brotherhood, a great sisterhood, and we pick each other up, and we don't see a lot of turnover in this job. And I think that's a lot of commitment to all the members at our sides that really help each other through these hard times. And if we get out on the other end of this, I know it's going to be challenging, but I just as lame as it sounds, I just look for those brighter days. And like I said, over these 14 years, there's ups and downs, and I'm ready to get back towards the ups.
Kyle, would you respond to that same question?
As long as there are trucks able to respond and our members are on them, we will keep going. And does that mean that it might not take us a little longer to get there? Yeah, maybe it will, because we're going to have to start stacking calls. If we start seeing more and more days, more and more shifts of 50, 60 calls in a 24-hour period, that's an operational stressor that I don't think this department is staffed for or set up to handle. I would push back. John had mentioned a little bit earlier, and this is the union side of me 100% speaking right now, that he says we're not understaffed. We are. The engine that Jeremy is a lieutenant on, it is only staffed by 2 firefighters. And a lot of people look at that and they say, well, what's wrong with that? You get the truck to the scene, you got 2 people there, you can do the job. Our job is one that responds to emergencies. Emergencies usually do not get better. The more time you wait, they get worse. So we want to do everything as quickly as we can and get there and accomplish everything that needs to happen. More hands equals quicker. The quicker we're able to neutralize that threat, to mitigate the extenuating circumstance, to make everything safer. So we do need more bodies on our truck to help carry this load, to shoulder this burden. It is not safe for engine 3, Jeremy's engine that he's on, for him and just the driver to show up to a suspected overdose in the middle of the night by themselves with dim lighting in the middle of the field with a bunch of unknown variables, right? That call requires both people to be laser focused on that patient. There's no one there to provide that overwatch, that scene safety. Those are the types of calls that are going to break the system. When the safety of the members responding starts to become to the point where we can't respond anymore because we can't operate safely. Not only can we ensure that we'll be able to provide care, but now we're talking about maybe we're going to get injured as well. That's where we'd be at that breaking point. I echo what Jeremy said, though, and I would be hard-pressed to find right now in our current department, in our current membership, a member that would sit here and tell you that it's too much and that they don't want to be here anymore. We're ready to carry the burden. We're ready to carry the weight, and we're going to keep marching on, but it takes a toll. But we're going to keep doing the job. We have had issues, though, historically with that turnover, where we went through probably a 3-year period maybe, where we lost, I think, over half, if not 3/4 of every new employee that we had hired within like a 2 to 3 year period of them being on the job, because they were coming in the door and they were getting on the ambulance and they were finally getting to see this is what it means to be a Burlington firefighter. And they said, no, thank you, not for me. It is no longer, there's no employee that can come through the door now that will tell you that they think our primary function is going to be fighting fires every day. We prepare them to know that EMS is a huge part of this job. Those fires that come in, that's the icing on the cake. Still someone's horrible day, not trying to say it's not. Someone's house is on fire, but that's what everyone signed up to do. To see that front door fully engulfed, grab the 1 3/4 line, and go to work and put out a fire. Like the morale in the firehouse after a fire is just on another level, because that's what it's those little shining moments that come through, because we got to hopefully save someone's residence, we got to save their belongings, and maybe we've even got to save them. Operationally, we're probably getting close. Staffing is of utmost importance, making sure that the department can continue to meet the needs of the community as the community changes what those needs are. But I'm not going anywhere. These guys aren't going anywhere. We just want the community to be educated on what we're dealing with, and and maybe when they see in the future there's a request to increase funding for more staffing or a new apparatus or some new trial pilot program that could offer a new unique solution, that they support it.
For me, I've been blessed with a lot of life experience before I reached this job, and so it's defining and definitive in my soul that this is who I am. Firefighting isn't what I do. It's not something that I hoped would work out. I found it and I identify now. And that comes from a long history of, from the Marine Corps and kind of everything else I do. I've always been looking for that service and that belonging, and I have it here. So for me, there is no breaking point, unless something physically happened to me where I would no longer be able to do the job. Because the most important thing in my life is doing what I believe I should be doing, and I believe that's helping people. And the icing on the cake is I get to work with gentlemen like these that are good friends of mine. There's nothing better. As far as our organization, I'd say that I don't know if a breaking point's really going to be like an acute fracture, like tomorrow we wake up and the fire department can't function. But what Kyle was talking about with the attrition rate and preparing new people, especially young people that don't have a lot of experience, for what this volume and what this fatigue and what the amount of fortitude is required to do this every single day is straining. And figuring out either with staffing or another solution that we come up with hopefully in the future to buffer that, I think is the only way we can kind of maintain in the role of dealing with the worst, which is what we love to do. But if we're unable to do it, then I think that, and not only from our point of view, for the society and for the people, like if you call 911, you expect the best, bright-eyed, high-energy, laser-focused people to come through that door and save you or your loved one or your house or your cat or your car or whatever's going on. So I think together we're all in this to try to enable a resolution for currently what's going on from, multiple different reasons.
John Husbands, Jeremy Raymond, and Kyle Blake, all members of the Burlington Fire Department and members of the Burlington Firefighters Association. I'm really grateful for your honesty and sharing your thoughts today. Thank you.
Yep.
That wraps it up for this edition of 802 News, brought to you in part by Red Hen Baking Company. I'm Mark Johnson. Thanks for listening.